Hi, I'm Walter Mashman, Deputy Editor of JACC Cardiovascular Interventions, and it's my great pleasure to be here today with Dr. John Webb, who's one of the pioneers in percutaneous aortic valve replacement. Dr. Webb has recently provided us with a paper studying heart block in this patient population, and we're here to discuss that. John, tell us a little about what you did with this paper.
Thank you, Walter. Well, we started several years ago with percutaneous and subsequently transapical aortic valve implantation. And perhaps we were a little naive, but we had thought that heart block would not be a major problem with this procedure. I don't know that it's a major problem, but it certainly is a recurrent issue. And so we decided to look at our experience with this. So we looked at patients undergoing both percutaneous transarterial valve implantation and transapical valve implantation with a catheter through a mini thoracotomy. And in all, we had at the time 123 patients that had a successful implant. So we looked at our experience in 123 patients and looked at the incidence of heart block on the postoperative electrocardiogram and examined the frequency of that. So in short, what we found was that it was a bit confusing because 14% of the patients already had a pacemaker in. So that needs to be taken into account when everyone talks about the frequency of pacemaker dependence after transcatheter valve implantation. And if you look beyond that, the incidence of a new complete heart block that was sustained requiring pacemaker implantation was 5.7% in the group overall, 7 patients, or 6.6% of the 106 patients that didn't have a pre-existing pacemaker developed new complete heart block and required a pacemaker.
Okay. And you had one patient who died 10 days of non-directly cardiac complications, and you were able to show the pathology of the histology of the myocardium there.
Well, there was one patient who died of bowel ischemia, not directly related to the heart block, indirectly perhaps related to the transcatheter valve implantation at a transapical procedure. And this patient at postmortem had some evidence of ischemic injury to the septum adjacent to the prosthetic valve.
And we gather then that we presume that that there's infarction or myocardial necrosis that contributes to the heart block. Was there edema seen as well? Is this a temporary thing?
Well, you know, this is only one patient, so we don't really know how often there's ischemia or infarction or versus edema. But I think we know that the conduction system passes along the left ventricular outflow tract right underneath the non-coronary cusp of the aortic valve, and it's commonly injured at the time of conventional aortic valve surgery. And reports of the incidence of heart block requiring pacemakers after conventional surgery range from 2% to 6%. That's the sort of ballpark. We think the incidence is a little higher in our patients because these are very high-risk patients. They have multiple comorbidities. They're typically very elderly. The average age has been in the mid-80s. The logistic Euroscore estimate of 30-day mortality had these patients had undergone routine surgery was 30%. That might be an overestimate, but the incidence may be higher in this particular subgroup. We don't have a surgical comparator to look at. But clearly the stents are compressing the conduction system adjacent to the AV node, and that's the problem.
Can you very briefly describe to me the issues regarding sizing and the trade-off between perivalvular leak and the potential risk for heart block?
Well, we looked at various things that might predispose to heart block in our patients, and it was difficult because of the relatively small numbers to pin this down. But all of our patients have a different size aortic annulus, and we have 2 sizes of available percutaneous transapical valves. And so there's always a variable ratio between the size of the valve we put in the patients and the size of their annulus. And you would think that the more you stretch that area, the more heart block you would tend to see. We had difficulty seeing this, but it seems reasonable that that would be the case. Our desire in our particular series was to put in a valve that was always bigger than the annulus. And the reason for this, oversizing of about 20%, was to try and minimize leaks around the valve or paravalvular leaks. It turns out with transcatheter valves that paravalvular leaks are actually ubiquitous, and initially people thought that this was a tremendous failing of this procedure. It seems, though, that the leaks are usually relatively mild and usually well tolerated and not as important as one would think. But the tendency is to put larger and larger valves in to minimize this leak, and there may be a trade-off, although it's difficult to show in our experience, in terms of a higher rate of heart block with excessive oversizing. It seems logical to think that.
Well, John, I really appreciate you talking to us about this very important topic. This will become more and more interesting as we gain experience in the procedure as a whole. Thank you for watching. This is Walter Mashman for Jack Cardiovascular Interventions.